Well, good afternoon and welcome to Medicine Grand Rounds. I'm David Guido. I'm the Division Director of Pulmonary, Allergy, Critical Care, and Sleep Medicine. Our chair is out of the country, and even if he were here, though, I'm sure he would agree to allow me to introduce our guest speaker today because it's someone I've known for 25 years and is both a colleague but also a close personal friend. So Fernando Holguin is visiting us from the University of Colorado. Fernando is originally from Mexico City. He attended La Salle Medical School there and came to Emory as an intern and resident. And from 1995 to 1996, he was the medical chief resident at this hospital under Juha Koko. And that was the year I was recruited to Emory. And I had the great pleasure of meeting Fernando during his chief year and the even greater pleasure of having him start his pulmonary fellowship in my laboratory. And I was a very junior faculty member, so Fernando is the first fellow I ever trained in the lab. To his great credit, he went on to a spectacular academic career in another field. And so the several years he spent with me did not scar him too badly or hold him back too much. So thank you, Fernando. And we became close friends. I've been to his wedding. I've met both of his children within days of their birth, and we've stayed very close friends. Fernando has had a spectacular career in asthma, in really outstanding original clinical research, clinical delivery, setting up centers. He broke our heart when he left Emory to go to Pittsburgh initially, but was recruited by one of the world's leading translational investigators in asthma at the time. She's still there. And then a few years ago, got recruited to the University of Colorado, where he and his wife relocated, and he runs an asthma program there, and it's just doing spectacularly well. So it's so wonderful to invite back an old friend, a great colleague, and someone with very strong personal connections to this room in this hospital. So Fernando, welcome back.
Thanks, David. Thank you all for coming. Thanks for that wonderful and warm introduction. It's really, I feel like being here is like being back home. Sat here many times listening to Grand Rounds myself, and so it's really a pleasure to be back. So I want to give today, this is a very clinical talk, so for the residents, don't be afraid. There's not going to be any major like pathways like we had this morning, but it's going to be, I hope, practical and to give you an idea where the field is moving rapidly and in a very exciting manner. So I started my interest for asthma a long time ago when my first job as a faculty member was at Grady Hospital, and I was directing the asthma clinic. And I became really interested on understanding why the people there were having such severe asthma and having such difficult problems with their disease management. Although at the time that I started my internship 27 years ago, Grady looked a lot more like that, except for the 1940 cars that are over here. That's the oldest picture I could find. But certainly a lot has changed, and even just walking through campus gives me an idea of how things have modified at Emory recently. It really is a lot about your mentors, and I've had a wonderful cadre of mentors throughout my career. Ken Walker welcomed me to the program when I was an intern, and I think without him I would not be where I am, and he really taught me to be a caring and compassionate physician. Juha Koko really taught me a lot about thinking critically about patient care, and I sat with him many times in morning report looking at cases. Roland Ingram was my division chief, and he did a lot of asthma research, and his work really inspired me to follow a career in research. And then, as David mentioned, I was his first fellow in the lab. And even though he tells me that, you know, what I did is went to different places, I feel that my career is continuing the same path. And David taught me how to really think critically and creatively about questions, because when I went into the lab, I didn't know anything. So a lot of what I do is actually very close related to what I did as a fellow. So thanks for that mentorship, David. So at the end of every recruitment day, when we see fellows at Colorado, Peter Hanson, who's one of our senior members in our division, comes to me and says, Fernando, no one wants to do asthma. And I get it. I get it. For the longest time, if you look at asthma management from 1990 to 2000, we were playing with 4 drugs. I mean, I was tired of seeing clinical trials that, well, if you modify that dose and if you add that, then you get that. And then the next trial was like, no, lower dose and higher dose of that. And it wasn't until recently that we really started to develop biological treatments that were very exciting. And I think more fellows are becoming interested, I hope, in asthma and airway research. And I think outside of oncology, in pulmonary medicine, airway management and asthma leads the precision-based interventions right now in pulmonary medicine. So right now, we're really going to talk a lot about individual treatment strategies. Managing from bronchodilator to inflammation era, this is mortality rates from 46 cities that was published for the Lancet Asthma Commission. Clearly, working on inflammation has made a major change in overall mortality rates, but we still have a lot more ways to go to manage the disease better. And one of it has been sort of started by thinking of asthma not as one disease, but as a complex different traits of different phenotypes. You have people that respond to environmental challenges differently. You have people that have different genetic and genetic expression compositions. You have individuals that have chronic airway obstruction. Some of them have variable, and so it's really all over the place. And you have people with different patterns of inflammatory airway mechanisms. And in those that metabolism influences their airway disease in a different fashion. Overall, what you end up having is not one disease, but a heterogeneous group of very complicated and complex diseases. So this is a bit complicated slide, but I just want to show you, today I'm going to talk about 4 cases to illustrate how asthma management is changing. And what's interesting is all these patients have asthma, and none of them, inhaled corticosteroids, would be adequate or sufficient to manage the disease. The drug that for the longest time was considered the hallmark of management of this patient only works in about half of them. So we're really moving into a different territory now. So I'll come back to those cases later. If you think about asthma as a complex set of phenotypes, you can think about people that develop the disease early in life. This is childhood onset of different severity categories with different spectrum of Th2, like eosinophil-driven inflammation. Allergic asthma onset dominates in people that develop the disease early in life. Later on in early adulthood, you see people that develop severe late eosinophilic disease, aspirin-exacerbated respiratory diseases. But then there's this subgroup that's over here to your right, where people develop asthma later in life, and many of them really lack all the T2 biomarkers that we normally see. And so these patients typically end up being not responsive to steroids and are associated with other comorbidities such as obesity and more common in females. So again, not one disease. And I want to talk a little bit about treatment response heterogeneity of one of the most common drugs that we use to manage this disease, which is steroids. So in SARP, one of the things we did a few years ago is we gave 750 subjects, we gave them a shot of triamcinolone in the gluteal area, and we characterized the response at the beginning and 2 weeks after. So this was part of their entry into this cohort study. And what I want you to pay attention is to this curve over here. It shows the actual change in FEV1, the absolute change in FEV1 before and after a shot of Kenalog, which is 40 milligrams of triamcinolone. So you can see that there's some people, both adult and pediatric, severe and non-severe, and some people have these large increments in lung function. But interestingly enough, a lot of people actually do worse with the steroids, and we often don't think about that. So not everybody responds, and only about 20% achieved a significant change of greater than 10% in FEV1. And if you look at inhaled corticosteroids, Stan Zeffler, who works at the University of Colorado, has shown that in kids. These are kids that were randomized to fluticasone and Montelukast with the goal of looking who would increase their FEV1 by 7.5%. So you wouldn't think 7.5% is a big deal, but actually achieving that degree of bronchodilation is complicated. And so what you see is that some patients with fluticasone for a few weeks, they increase their FEV1, a lesser amount respond to Montelukast, which is an anti-leukotriene blocker, and then some respond to both medications. But guess what? 55% of people don't respond to neither, right? And these are standard drugs used for children and adults. Perhaps one of the reasons why not everybody responds is because they have different genetic composition. This study that was done by Prescott Woodruff a few years ago shows that if you look at the epithelial gene expression of 3 enzymes, in this case, periostin, CLICA1, and serpin-B2, which are in the T2 pathway, you'll find that there's a hot group of people over here on red that are high expression of these enzymes, and there's this group that are low expression of these enzymes, and there's some controls in here. And those in red tend to have higher levels of eosinophils and IL-5 and IL-13, which are T2 biomarkers. But more importantly, those that have this high expression of these enzymes, when you treat them with inhaled corticosteroids, their lung function goes up quite a bit, which is this red line over here. Whereas if you look at those that are non in this pathway, their FEV1 goes down. So clearly, and this only tells part of the story, clearly there is a different phenotype that responds to steroids and it's a phenotype that does not. For this group, now we have a lot of different cool therapies, I may add, but then for this group that's non-T2, we don't have much of anything yet to offer. This is not a unique idea. In 1958, Morrow Brown published in The Lancet, he treated patients based on eosinophilic sputum and those with no eosinophilic sputum, and he gave them 5 milligrams a day for 3 days a week. which is like nothing, right? This is absolutely nothing. And patients even had a hard time coming off the medications because they felt great. But when you look at it, is that those with eosinophilic in sputum, 100% got better, whereas only 40% with no eosinophils improved. The sad thing is that it took us another 60 years to get back to this. So, and what you see, this is the eosinophil blood distribution in absolute count of people that participated in SARP. So it's about 1,300 patients. And what I want you to pay attention is the median distribution. So the median distribution of absolute eosinophil count in the population is around 200. Why is this important? Because 200 is what buys you into biological therapies or not into biological therapies. And what else is important is you're going to find a lot of people above that are under 200 that you're going to manage and you see in your clinic, and they won't respond to steroids sometimes, and they won't respond to biological therapy. And if you look at severe, these are only severes from SARP, is the same exact distribution. 200 seems to be a very standard median for eosinophil levels. In sputum, the same thing happens. These are 350 naive subjects for ICS naive that were on ACRN that had 2 or more sputums, and this is considered eosinophilic if they have more than 2%, which is sort of standard. And what you see here is that at baseline, 64% of subjects have non-eosinophilic sputum, and then if you follow them through time in several repeated measurements, roughly half of them remain non-eosinophilic. Again, the way to think about it simplistically is that in asthma, half of patients have eosinophilic disease and half do not have eosinophilic disease. Now we've come a long way where we used to prescribe cigarettes for asthma. Asthma cigarettin and asthma cigarettes. These are actually, there's some idea behind them because they had alkaloids, and alkaloids supposed to like act on your muscarinic receptors and bronchodilate you a little bit. Certainly they would have a lot of byproducts that would be toxic. But in this editorial from Jeff Drazen, shows that in spite of all the progress that we have achieved over the last 2 centuries, because if you read this editorial, if you're interested, it's quite great because it actually talks about an asthma case in 1928, and 2012. And what you realize is that what we do still rests a lot on trial and error, and we don't know fundamentally what causes asthma. So I'm going to start with some of the cases. And these cases, with these cases, I'm going to illustrate some of the most recent managements and what I think is exciting in the field. So these are all real cases from my clinic. So a 28-year-old female patient comes with late onset disease, so after childhood, persistent daily symptoms, mild airway obstruction, does not exacerbate. So I sort of highlighted the keywords over here. Does not exacerbate, has daily symptoms, but doesn't have any eosinophils and doesn't have any XLNO, and none of her T2 biomarkers are elevated, right? So if you think about this patient, given the persistence of symptoms, this patient would normally be prescribed a daily inhaled corticosteroid. Yet, given her lack of T2 inflammatory biomarkers, would this be the best approach, right? Because we've already seen that if a patient is lacking T2 biomarkers, may not respond to inhaled corticosteroids. So one of the studies that we did in AsthmaNet that we recently published is we randomized 295 patients that had persistent asthma. And what we did is we randomized based on whether the eosinophil was low or high. And it's a crossover study to either placebo, tiotropium, which is an anticholinergic antagonist, a long-acting muscarinic antagonist, or inhaled corticosteroids. And the idea was to see, do people respond differently based on their entry of eosinophil levels in the airways? And so in patients with, and I'm going to show you the adult data, but the child data looks similar. The eosinophil low disease, those who had less than 2% of the sputum, when treated with inhaled corticosteroids, it was no different than placebo, right? And based on the previous slides, you were very like, that makes sense. But what's very interesting is that those treated with long-acting muscarinic antagonists did better than placebo, suggesting that perhaps for a non-eosinophilic patient who's mild persistent, you should probably try something like tiotropium instead of inhaled corticosteroids. Those that were eosinophil high, as you would expect, inhaled corticosteroids did much better, right? Whereas LAMA was no different than placebo. You would argue that airway eosinophils are very hard to get and only specialized centers do. But in this study, we looked at the response ROCs and found that actually blood eosinophils are good estimators, not perfect, but are good estimators of airway eosinophils. And so going back to the clinical case, in this patient with persistent symptoms and no eosinophils, a LAMA could be a reasonable first choice. And that's probably going to be reflected on the next coming guidelines. So this second case is a 40-year-old male with late onset disease, not optimally controlled, no eosinophils, again, code words, right? Moderate airway obstructions. But this is a gentleman that exacerbates 2 or more times per year, and they're usually severe. He ends up in the emergency room, right? So this patient remains uncontrollable on inhaled corticosteroids and long-acting beta agonist. And the question is, in someone lacking eosinophilic airway inflammation or systemic inflammation, which approaches can be taken to improve his lung function and reduce exacerbations rate? Now, this is a person that's not symptomatic all the time, but exacerbates seriously, right? So and yet lacks any type of T2 inflammatory biomarkers. So this is a little bit more on this patient. Poorly controlled with ICT less than 19 is poor control, moderately airway obstruction, and then multiple laboratories show that his IG is normal, his eosinophils are normal, his XL nitric oxide is normal. And then this patient has significant remodeling changes with sort of basement membrane thickening and muscle hypertrophy, right? So what do you do with this patient, right? How do I help them? If I put this patient on daily inhaled corticosteroids, he's going to come back to me and say, you know what? I'm not getting in the benefit. I'm not feeling the love for this medication. I don't want to use it. And so, much to the pain of my infectious disease colleagues, one of the things that we've been exploring is the use of chronic macrolide therapy to reduce exacerbation rates. So in this study that was published in Lancet, it was called the AMAZES study. They randomized 420 patients who were symptomatic and uncontrolled on chronic controllers to 500 milligrams of azithromycin three times weekly, with the idea of what would happen to exacerbation rates. So here on your left, you see that those on placebo throughout the study continue to exacerbate more compared to azithromycin, and the incidence rate is about 40% less on those treated with azithromycin compared to placebo. So in this patient, it would be a good option, because one of the subgroup analyses showed that regardless of whether you're eosinophilic or non-eosinophilic, you tend to respond to macrolides for exacerbation reduction. And interestingly enough, this is from the same study, but it was a reanalysis using sputum samples. Azithromycin was associated with a significant decrease in the total diversity of taxa, including a significant decline in the in Haemophilus influenza, but there was a significant increase in the carriage of antibiotic resistance genes. So it doesn't come without a cost. And I think one of the things that the studies have done up to a year is that they don't see increased frequency of resistant pneumonias, but the data that we have is only to about a year. Nobody knows what would happen beyond that. So let's talk about this case. It's a 38-year-old male with, and note the keywords, early onset disease, so remember more T2 driven, right? High eosinophils, allergies, minimal daily symptoms with good control on PRN short-acting bronchodilators and normal lung function. Yet this patient does, on a regular day, does great, but once this patient gets a viral infection, gets into trouble. And this patient has 2 severe or more exacerbations for asthma every time this gets into a viral exposure. So this patient is well controlled, only using albuterol as needed, does not meet criteria for a daily controller. He will not take it, I can guarantee you that. Yet he's hospitalized at least twice yearly. What would be the best approach to manage his symptoms while reducing his exacerbation rate? So how do we prevent exacerbation rate, but without putting the patient to the burden of taking something on a daily basis? So some points about, because my life is so focused on severe asthma. I normally don't talk about mild asthma, but there's some interesting changes that are happening in mild disease. So one thing to remember is that severe exacerbations in patients who have been classified as having mild asthma represent 30 to 40% of the asthma exacerbation leading to emergency room consultation. So many of the people that use in the emergency room, if you would classify them, you would classify them as mild, but yet they're in the emergency room, maybe needing to be hospitalized. And the other thing is that adherence to these patients is poor, right? So 30 to 40%. And you can try, let me tell you, there's adherence literature, a lot of papers. It doesn't work. The adherence cannot increment beyond 40, 50%. It's really bad. And the reason is because many of these patients don't improve, right? They don't feel better, so they don't take it. So the other thing that's important to remember is that overuse of short-acting bronchodilators is associated with increased mortality. This is a well-known phenomenon. Patients start to feel bad and they start to overuse their albuterol, and that can get them into trouble because of downregulation of receptor and getting into increased mortality. So the recent trend in managing mild asthma is called smart therapy. So I'm going to show you, there are several studies that are published. This is one of the most meaningful by Paul O'Byrne from Canada, a multi-center study in which they randomized patients to a albuterol, in this case was terbuterol, placebo versus budesonide on a daily basis, or long-acting beta agonist, which is in this case formoterol, and budesonide. So what they did is they took a drug that's normally is used for step 3 control, which is long-acting beta agonist and inhaled corticosteroids, and told patients, you know what, use it as needed every 6 hours, no problem. Which you remember that the FDA had a lot of issues with toxicity, but the data showing that actually is very safe. And what the study shows is that this is the probability of having a severe exacerbation during the study. Dosing in albuterol alone continued to exacerbate at a greater rate, whereas those on inhaled corticosteroids on a daily basis or long-acting beta agonist and inhaled corticosteroids as needed do about the same. So what do we get back from here? Is using as needed long-acting bronchodilators with inhaled corticosteroids as safe, superior to short-acting alone, and non-inferior to ACS maintenance. So it's about the same as using an inhaled corticosteroid, but adherence improves quite a bit. Almost, 65% is quite significant, and you reduce exposure to long-term inhaled corticosteroids by as much as 2/3. So you allow the patient to dose themselves with anti-inflammatory and long-acting bronchodilator as needed instead of having to use it on a daily basis. And that has changed the global international guidelines for asthma. The GINA guidelines has changed their position recently. This year, in the past, the recommendations was for people with mild persistent just to use low-dose inhaled corticosteroids and albuterol as needed. And now they're modified, this is their current guidelines, to use Symbicort, which is formoterol, and budesonide as needed for step 1 and step 2, and they even advocate to use it as a preferential reliever medication, even in people with more severe disease. So again, this is something that we can do now, and one of the things that you need to remember is that this is not FDA approved yet. It's being used in Europe, it's being used in other countries, but in the United States it's not approved. It's not an approved management. So 46-year-old female patient with late onset severe asthma, again, late onset, severe, poorly controlled, moderate airway obstruction, highly eosinophilic, requiring daily oral steroids, several sinus surgeries for nasal polyps, and severe exacerbations per year. This is a patient that's, Ann could tell you, this is a patient that's in the asthma clinic, in the severe asthma program. Patients who are typically on a daily oral corticosteroids. They may or may not have aspirin-exacerbated respiratory disease. They're very sick. They don't feel well. These are patients that are hardly ever off steroids, right? So they have a lot of comorbidities because of that. So the patient remains poorly controlled and exacerbates despite being on triple inhaled therapy and systemic steroids. So what additional treatment can we offer a patient like this, right, to reduce the burden of exacerbations and also try to improve their nasal polyps and the chronic rhinosinusitis? I'm going to talk a little bit about this phenotype for a moment. So this is data from SARP, from Severe Asthma Research Program. It's a cluster analysis, a non-biased approach where they come up with 5 clusters of different patients with different phenotypes. Obviously, based on the arrows, I want you to concentrate on number 5. So number 5 is patients with adult onset disease, highly eosinophilic, with severe rhinosinus disease and polyps. So these patients are more often seen in the emergency room than not. They visit the emergency room, they get to the ICU more frequently than the other groups. They have reduced lung function. And of course, they had a lot of surgery to remove polyps. So whenever you see a patient like that with polyps, it's a bad sign. It's a sign of severity, it's a bad disease. So there are a lot of new biologicals. I'm not going to go into all the monoclonal antibodies that we have right now, but I'm just going to use this as an example for 2 drugs. So we have now good evidence that using anti-IL-5 or anti-IL-5 receptor therapy and anti-IL-13-4 therapy blockers can actually reduce the amount of systemic corticosteroid exposure. So in this study, patients were randomized to benralizumab, which is an anti-IL-5 receptor blocker. And here you can see the change in corticosteroid dosing compared to placebo. So at week 16, there's about a 75% reduction on a steroid dose. I never thought in my whole career treating patients with asthma that I would get to this point to be able to get some of these patients off steroids, because you're always like, try this week to come down for a few milligrams and they come back next week. I'm feeling terrible. Then you go up and then you go on, you go up and you go on. And so here it works. You can reduce steroids and at the same time, the exacerbation rate drops. This is placebo and this is 2 doses of benralizumab. The other drug that can be used quite effectively is dupilumab, which is an anti-IL-13-4 drug. This is 200 asthmatics with corticosteroid dependency on an average of 35 milligrams per day. And you can see when treated compared to placebo, the dose is a very significant drop, greater than 60%, 70%. And in this particular study, about half of the patients that were treated with dupilumab were able to come off completely of steroids, which is really quite remarkable. And at the same time, their lung function, which is a blue line, FEV1, compared relative to placebo. So these patients do better, they exacerbate less, their lung function goes up, and you get them off steroids. And if you look at this is just one study, one recent study looking at severity of polyposis and chronic rhinosinusitis, and those treated at week 16 with dupilumab have about an 86% reduction in the severity of their rhinosinus disease. So some of these drugs can affect their upper airway as well as the lower airway very effectively. This is a very busy slide, but just to illustrate that we have right now 5 drugs that are approved. One works on anti-IL-4/13. Benralizumab is an anti-IL-5 receptor blocker. Reslizumab is an intravenously administered anti-IL-5 medication. Mepolizumab is now sub-Q, and you can do it at home. And then omalizumab, which is the oldest one, is IG, and they have all different criteria of IG and eosinophils that you have to have elevated in order to qualify. And it's always a challenge with insurance companies. Different insurance companies have different benchmarks you have to meet. They typically have to exacerbate. So when you're somebody who meets the criteria for eosinophilic disease, has been exacerbating, they're on maximal therapy, that could be a candidate for these type of drugs. The worst slide ever, but I just want to show you that there are a lot of new drugs that are coming down the pipeline. TSLP, it's an anti-stromal lymphopoietin antibody, which has a lot more broader anti-inflammatory effects. I'll talk a little bit about that. CRTH2 with PGT2 antagonists. So a lot of new drugs are under development. So it really just like warns me to tell you that the management of asthma is just getting even more exciting. And I wouldn't be surprised if by 5 to 10 years, we have 10 or more different biologicals to manage these patients. So tepezolizumab is a drug that's on phase 3, that's completing phase 3, which is an anti-thymic stromal lymphopoietin. So this is something that the epithelium releases when it gets exposed to different noxious organisms or virus or pollutants. And it really affects both Th1 and Th2 pathways. So this is a phase 2 randomized placebo-controlled study, 52-week, a year long, on poorly controlled asthmatics. And what you see is that patients that are compared to placebo, those that are randomized to tezepelumab have about a 71 or 66% reduction on exacerbations, while their lung asthma control improves significantly. So very effective drug. This is a bit busy. What you see, this is a placebo. This is the annualized rate of exacerbations. The gray ones are the placebo. These ones are different doses this is a phase 2 study. But what you clearly see is that you get a very good response regardless of the dose and whether your eosinophils are low or high. So all of us in asthma are very excited, anxiously awaiting this drug, because this is one drug that could potentially be used for people with non-eosinophilic disease. Now, all of these drugs are based on your eosinophil levels, but this is a reanalysis of 2 large studies that looked at benralizumab, the Sirocco and Kalima. And these are forest plots of post-hoc evaluations, and clearly you can see that there's a difference in response based on age. We don't know whether this is going to be as effective. This is favoring placebo on people that are adolescents. So there's a lot of questions about whether it's going to work on younger folks. Blacks don't seem to respond as well as whites, and those that are larger BMI don't seem to respond as well. So there's a lot of response variability, even with these drugs, driven by eosinophils, FEV1 reversibility, but there are also a lot of different factors that may determine why a person responds or doesn't respond. So this is how we do it. This is how we do it in Colorado, but it's not exclusive. I think this is how everybody does it. So when you see patients that are severe disease and have problems, it's important to confirm the diagnosis. Data that we've published and others have published really shows that 30% of people that are diagnosed with asthma that come to asthma referral centers do not have asthma. And I can tell you that on a daily basis in my clinic, I did diagnose as many people I diagnose. So you always have to look for asthma mimickers and other complex airway diseases. Once you confirm this diagnosis, but with objective testing, I might add, you have to identify which is a phenotype and endotype. For me, it's very important. When do you develop asthma? Is it a younger age? These are individuals that have typically more allergic, eosinophilic on the spectrum. I look at history of prior exacerbations very carefully. I look at race because, for example, we've shown in SARP that African Americans have especially early onset, have a very IgE-dependent disease. So you have to look at race carefully as well. What are the peripheral eosinophils? Nitric oxide, IgE, do they have polyps? Do they have other comorbidities? Do they have obesity? What is their lung function? And then based off that, if they meet criteria because they're severe, they exacerbate, they're eosinophilic, they meet criteria for eosinophilic, and they're exacerbator and they're on triple therapy, that means they're on a long-acting beta agonist, long-acting muscarinic antagonist, and inhaled corticosteroids at high dose, then you can put them on any of these drugs. If you see somebody who's steroid dependent, their eosinophils are typically going to be 0. So in those patients, you can put them on dupilumab. The FDA has approved them. You don't need eosinophils on patients that are severe steroid dependent. And this is also a good drug for someone with the FDA just given clearance as a drug to treat chronic rhinosinusitis with polyposis that refractory to therapy. It's also as an indication by the FDA to treat severe refractory atopic dermatitis. And we reassess response every 4 to 6 months, because one of the things that we've learned that was not really described in the clinical trials, and I talked to my colleagues here at Emory and other places, is that we're seeing about a 30% biological failure rate. I mean, patients come in, you give them the shot, they feel great, they do great for 6 months, and then they tell you, last time you gave me that shot, the benefit only lasted for 3 weeks instead of 4 weeks. And then they come back, 2 weeks. And then, a few months down the road, they're like, this is not doing anything for me. So a lot of us are looking at different pathways to try to understand why these agents are failing. But there was an interesting study that was not published, but presented at the ATS last year, showing that the high failure rate of anti-IL-5 monoclonal antibodies are associated with the development of the formation of heteroimmune complexes of anti-IL-5 monoclonal antibodies plus anti-IL-5 and endogenous polyclonal antibodies with subsequent complement activation. So some of these individuals develop antibodies to these monoclonal antibodies and reduces their efficacy. We have a study ongoing looking at nasal epithelial gene expression that we just started, where we're actually testing different gene expression pathways before they get into it, and then at 3, 6, and 12 months. There are a lot of uncertainties regarding this therapy. There's complete lack of evidence of what happens long-term. So the studies right now, the safety only goes for 2 years. And then patients ask me, I feel great, but how long am I going to be treated? And you just like shrug your shoulders and be like, who knows? There is no clear definition for a response therapy to guide patients and clinicians in deciding when to stop one therapy or insufficient effect to consider switching to another. So what's happening is that people come and ask me all the time, how do you choose one versus the other? And it becomes a very pragmatic decision making. So we don't have good tools as to what should we do first. And if you fail that one, what should you move to the next one? Everybody's developing their own algorithms. So it's really an imprecise precision medicine approach to some level. To the point that Jeff Drazen put an editorial out, said that if we do not take head-to-head approach, which is pragmatic comparative effectiveness trials, we will end up prescribing the treatment with the most effective marketing. So think about that. Our patients deserve better than that. So what's happening is because the companies will never allow their drugs to be tested head-to-head. What they do is they test it against placebo, but that's really hardly ethical. And what we need to do is do comparative clinical effectiveness to understand which biological works for different patients. So according to the Institute for Clinical and Economic Review, it is unethical to continue to perform placebo-controlled trials in high-risk patients. Requiring an active comparator in clinical trials would also improve patient and clinician understanding of the relative benefits and risks available treatment options. So with that, some of us are participating in PRECISE. PRECISE is a new NIH network. And it's an adaptive trial design, and we are doing completely out of the box treatments that actually are very exciting and attacking different pathways. Stay tuned. We've been working very hard in collaboration with my colleagues for the ERS and the ATS. And so we will put in the guidelines. We're releasing the guidelines in Madrid in 2 weeks. So a lot of what I described today is going to be published in just a couple of weeks. The Lancet Commission is a really nice compendium that just was published in Lancet by the top world experts in asthma. And it's really worthwhile to read if you see these patients. So I am one of those people who really urges the fact that use the term asthma solely as a descriptive label for collection of symptoms with no assumptions about pathophysiology. Asthma is a bad term. It's like saying, oh, you have anemia. Then people will be like, well, what kind of anemia? Or you have arthritis. Well, what type of arthritis? So telling somebody asthma is just, to me, is telling you have a constellation of symptoms. And what we need to do is find out what's leading those symptoms. So the idea is to deconstruct airway disease into component parts before planning treatment with a focus on traits that are identifiable and treatable. So you really want to get to those treatable traits. This is again from the Lancet Commission. So what we need is more, I love this phrase, what we need is more right drugs for the right lungs and not just more drugs for more lungs. And so if you have asthma, it's just telling the patient you have anemia or arthritis. And I think Anna and I were talking later that the drugs that we're using right now, because they're, the advertisements come out. And so if you have eosinophilic disease, ask your doctor to give you Fasenra. And so people come to my clinic, it's like, do I have eosinophilic disease? So it's kind of catching up a little bit, that there's more than one disease in here. Asthma is just a complex definition for a complex airway symptomatology, not a specific disease process. And this is from a patient that published a picture on the Lancet Commission about what her feelings are to be a severe asthmatic. And with that, I'm happy to take any questions. Thank you.
Thank you, Fernando. If we have questions in the audience, we can get to the microphone. Maybe I'll start by just saying it's a bit of a catch-22 in that you say asthma is symptoms, not pathophysiology, but then you say patients come to you with a diagnosis of asthma and 30% don't have asthma. So are you saying those 30% don't have those symptoms, or what are you saying? And give us an idea of what the mistakes are made, because if someone has cough and wheeze and shortness of breath, and we say they have asthma, that's based on their symptoms perhaps. But what are these mimickers? What do the other 30% have?
Thanks, Dave. That's a really good question. In our experience, mostly it's upper airway disease. So we see a lot of patients with, vocal cord dysfunction or paradoxical fall movement disorders. A lot of people with other chronic airway diseases such as bronchiectasis, chronic cough syndromes without any evidence of airway obstructions. And one of the hallmark studies that come from National Jewish several years ago showed that, for example, patients with severe with vocal cord dysfunction, the average time to the correct diagnosis is about 10 years. And many of these patients have gotten really sick from getting steroids. So we need to, when patients come in, and this is the big red flag that I hope the residents remember, is when you have somebody that tells you, I have asthma, I have symptoms, and then you do lung function testing, which not everybody gets, but you should get lung function testing, and there's no airway obstruction, and the patient is symptomatic, they can't have asthma. There has got to be something else, because the hallmark of the disease is airway obstruction. So when the disease is in doubt, you have to really go for the evidence of methylcholine testing, airway function testing. So we really do, we go all the way to make sure that I take people, I've been even running outside the hospital and then test patients before and after to see if the airway drops. I mean, whatever it takes, but you want to see that airway obstruction happen.
We have questions from the audience here or from outside sites. Looks like Dr. Law is getting up, either to exit or ask a question. I'm not sure which. Now you have to ask a question.
I'll put you on evidence.
I don't know.
I lost those skills a long time ago. Okay.
A comment, the quote that, a comment from the field of rheumatology. So the quote that you mentioned about the ethics of some of the clinical trials for these very exciting new biologic drugs is really well taken. And especially in the field of rheumatology, I think we've had, etanercept came out in 1997. So we've had several more decades of experience with biologic medications for our patients. And I think the joke among rheumatologists is, we cannot stand to have one more TNF alpha inhibitor hit the market. But the reality is, once we had 3, that was really enough before you needed to decide that you moved on to another biologic treatment. Right. But that the drug companies continue to make them because the way that the clinical trials are set up is that all you need to do is show that your new 4th generation or 12th generation TNF alpha inhibitor is better than placebo. And so I think it will be very interesting, and I think it's nice to see that in your field that this conversation is being had more broadly about how do we design clinical trials, how do we fund clinical trials, and what is the data that will help us make the best decision for the patients rather than which drug company can, message most directly either to the patient or to us about the medications that are appropriate for them. In the history of what we've learned from using biologic treatments in rheumatology, I think what we know is that some biologics do lose their efficacy over time as patients develop antibodies. So where are we in terms of determining for asthma patients if they are developing antibodies? Can we test for that if they're developing antibodies to the biologic treatments? And also, have there been studies looking at patients who possibly might benefit from another disease-modifying agent like methotrexate or leflunomide or something to possibly extend the efficacy of the biologic treatment?
That's a very good question. We don't have antibodies yet. I think that can be other than in the research arena. Some patients, and I haven't seen this myself, I'll see what maybe, but on things, but some patients that fail their eosinophils start to creep up again, giving you sort of like an idea that maybe they're not being as efficacious as well. We use other disease-modifying agents like Imuran and mycophenolate with variable degree of success. But again, I don't think we understand which patients should they go for. But if we have patients that have failed biological therapy that are doing great, or mycophenolate and Imuran combinations, which are a little scary because, yep.
So thank you, Fernando. That was very nice. I think one thing that you forgot to mention is that your career in asthma really got launched when you went to Mexico and started working there with people that, like Isabel Remio and others that were experts in asthma, and you started doing some really interesting work. And part of the deal is that Mexico City has a lot of asthma because of pollution, particulate matter. So my curiosity is about the impact that climate change, pollution, and other things are having on the ongoing asthma epidemic that we're seeing, particularly in people in the inner city and developing countries through, in-house pollution, stoves. And what is more of the sort of public health approach to addressing some of those issues, rather than what can we do to prevent asthma rather than just continue treating asthma?
Right. Well, how long do we have?
We have about 20 minutes.
Right. So, I mean, it's a very important question. Unfortunately for asthma, there's very few things that are sort of in the linear dose response relationship. So, for example, if you look at China, the worst pollution ever, yet the prevalence of asthma is only around 2 or 3%. Mexico has a lot of asthma, but in general, not as high as some of the other industrialized nations. So it's not only pollution, but it also has to do with early life exposures. So I'm a big believer at some level on the hygiene hypothesis, and that's been shown over and over and over again. For example, we published data from the CDC many years ago, where if you take Mexicans that migrate from Mexico to the US, when they come in, their asthma prevalence is around 4%, but if you follow them long enough, their asthma prevalence doubles, and in some instances triples. So this issue about genes and environments that becomes a very complicated paradigm. But I don't think that we have great prevention, Carlos. We don't. There's therapy now that has been implemented in high-risk populations where they're actually taking, again, my ID friends will not like to hear this, but they're actually taking lyophilized bacterial cell wall products to prevent the development of T2 immunity. So that might pick up. We'll be hearing some results pretty soon about that. And I'm married to an infectious disease doctor, man. Like every time I tell my wife that I'm putting somebody on macrolide therapy, she's like, "Don't do it. You can't do that."
Thank you, Fernando. That was a masterful talk on asthma. So it's clearly culmination of your expertise over 20 years. It's fantastic to have you here. Let me just ask a simple question. When do you think primary care physicians should refer patients to the specialist, not just when they can't, a refractory patient, but when do you recommend that? And then the second question is, so from your data, it seems like the non-T2 asthma, we really don't have anything else. Do you have any other thoughts about what may be coming down the pike aside from azithromycin and the LAMAs?
So the first question, I think, I'm obviously a little biased, but the people we want to see are people that are failing standard therapy. So people that are on triple combination inhaled therapy, or that are on systemic corticosteroids, or people that continue to exacerbate despite being on adequate therapy. Those are good referrals to an asthma center. In general, those are the patients we see. I don't see patients that come in, they're like, I love my inhalers. They come in like, I hate my inhalers. And so that's sort of always the starting point, right? For T2, I think anti-TSLP, there's some data that perhaps fevipiprant or CRTH2 antagonists. There's data that some studies looking at metabolism potentially could affect the onset of asthma, because not every asthma is airway inflammation. There's a lot of metabolic derangements that can be modified. So we have treatments with, as you heard early this morning, with L-citrulline. There's mitochondrial disease modifier drugs that are being used. So there's a lot of different non-T2 pathway drugs that are coming up, and I think we'll have a lot of more drugs available in the next 5 years. Yes.
You need the microphone.
Testing.
Yeah,
oh, here we
there
go.
you
I know we can use inhaled or fractional excretion of nitric oxide as a marker of airway eosinophils. How does that compare to looking at sputum eosinophils versus peripheral eosinophils, is there any benefit to pheno versus just peripheral eosinophils?
So that's a great question. You know, they are and they're not correlated. So eosinophils don't drive nitric oxide necessarily. It's more of a anti-IL-13. It's more of an anti. It's more of an IL-13. So it's more of some cytokines related to the T2 pathway, but not necessarily eosinophils. Eosinophils can and cannot be associated with high levels of nitric oxide. Depending on the biological therapy, for dupilumab, nitric oxide is as good as eosinophils for predicting response, but not so much for the other biologicals. But ENO is a very poorly understood molecule because I think low ENO in the right patient is bad. So,
We have any questions from outside sites? Okay. Well, Fernando, no one ever complained when Grand Rounds ended a few minutes early, but you're a great example that you can always come home again. And we're delighted that you still see Emory as one of your professional and personal homes, and you're welcome back anytime. So thank you again for joining us.